February comes and we haven't done any of those great plans. And I think the reason here would usually be you kind of intended to do something, but you then didn't plan how you're going to do this. And then you didn't actually follow through with your intentions. And very often people will go with this kind of black and white thinking where, you're kind of off the wagon and you're no longer on a diet. So you may as well continue with no longer eating healthy.
Yes.
So if you look at this from a psychology perspective, that's a classic example of relapse.
Perils of comparing yourself to other people on social media who are posting their highlights but not understanding the nuances, like you said there.
As uncomfortable as it is to get disagreeing voices or to get people who may try to put you down or be negative, at the end of the day, you want to have a meaningful piece of research. You want to have an impactful product.
Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment.
Hello, everybody, and welcome back to the show. Today, we are joined for a wonderful discussion on all things health behavior change with the great Dr. Dom Kwasnicka. Dom is a principal research fellow at the University of Melbourne and is a behavioral scientist. She's a highly influential researcher when it comes to promoting sustainable health behavior change in behaviors like physical activity, healthy eating, and reducing substance use. Dom also has a really cool blog called Practical Health Psychology, where she and other researchers break down health psychology research into practical information, tools, and strategies which you can use in everyday life. You can check that out in the show notes of this episode. In today's episode, we discuss what are some of the more effective strategies that you can use to improve your own health behaviors, how to make health behaviors like exercise and healthy eating habitual, the windows of opportunity that come up in life in which you can take advantage of to change your lifestyle and healthy habits, how healthcare practitioners like doctors and psychologists can improve their own practice in guiding patients to make sustainable health changes, and much, much more. Many of our episodes focus on the health behaviors themselves, like exercise and how it improves outcomes like cognitive or brain functioning and reducing depression. However, this is a really important episode because it's all well and good to know that exercise and certain diets like the Mediterranean diet can help you with your mental health. However, going about making those changes and making them habitual and sustainable is just as, if not more important. And that's really the focus and the crux of this episode. As always, if today's episode brings value to your life, we would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you love and care about. That's how we continue to grow the show, get the word out, and really try and help more people make positive health changes with their exercise, eating, sleep, other lifestyle behaviors to improve their mental health. Thanks so much for tuning in, and now to the episode on health behavior change with Dr. Dom Kwasnicka. Dom Kwasnicka, welcome to the Mental Wellbeing College.
Thanks for having me.
I hope I pronounced your surname right. I didn't actually check beforehand. Did I absolutely butcher it, or is that an okay Polish pronunciation?
So it's Kwasnicka, but most of my friends don't quite pronounce it well, so it's totally fine.
Okay, yeah, I absolutely butchered that, but okay, we'll persist nonetheless. No, thanks for joining me. Really excited to speak to you about all things health behavior change, both from a consumer perspective, everyday person, but also from a clinician perspective, healthcare practitioners. Seems like a very important topic for many people listening as well. So I think to start us off, Dom, I'm curious, what are some of the more common health behavior change strategies that people can use to change their own behaviors?
Great question. So I think the very easy one and the one we all familiar with would be around planning. So there's a lot of science around action planning, coping planning. Myself and some colleagues also reviewed some literature and did a lot of studies on this. And the science here is around the topic of implementation intention. So basically, if you have an intention and if you want to implement it, it's very good if you have a strategy. The science is around implementation intentions. And I'm sure you're familiar with, the idea of New Year's comes and we all kind of have this great intention of we're going to quit smoking, exercise more, we're going to, drink less. And then I think very often what happens is, February comes and we haven't done any of those great plans. And I think the reason here would usually be you kind of intended to do something, but you then didn't plan how you're going to do this. And then you didn't actually follow through with your intentions. So psychologists talk about intention behavior gap. And one of the tools how to overcome it is basically planning. So another thing is around coping planning. And that's basically planning for situations when you're going to fail. So, you said, I'm going to exercise this week. It's all going to be, great and easy because you like exercise. But then it's also about thinking about, what can go wrong? What are the barriers? What are the facilitators? So, simply planning for what you're going to do when those barriers arise, and also what sort of barriers are you likely to experience. So I lived in the UK for 10 years, and I think, even though I love going running, I did not love going running in the rain. So I guess the kind of coping plan and strategy would be, if it is raining, you just, do something else. You go to the gym, you have a plan B for that situation. And then relapse prevention, it's around, when you experience those barriers, what do you do if you don't follow through with your plan and if you kind of fail, inverted commas, what do you then do to go back on track? So that's the whole science of relapse prevention.
Okay. So there's a lot to unpack there. This term of implementation intentions, Dom. I remember when I first came across it in a health psychology lecture in my postgraduate psych studies, and I remember thinking, can this really, these health behaviors are so hard to change. Things like exercise, like you said, can just making a plan really, change someone from being physically inactive to being active. So I'm curious, what are kind of like the effect sizes, or I suppose, what's the degree of impact that this can have on someone, for example, who's inactive to, make exercise, like you said, or going for a run more habitual or more of an actual health behavior that they do regularly?
I definitely don't have effect sizes for you.
Yeah.
I know the review that you would be able to check this in is Gollwitzer and Sheeran.
Okay.
They basically looked at several studies that people intended to do something, and then in one arm they had a plan. They basically said, this is how I'm gonna implement my intentions. And in the other ones, they just had an intention, but not necessarily the plan. So in this review, they will give you the exact effect size for implementation intention. It was quite significant, but I can't remember exactly what it was. Myself and some colleagues did similar systematic review. Again, I won't quote effect sizes, but the one we did was on coping planning. And we published this ages ago. So that's 2013, when we basically did a very similar review to this one by Gollwitzer and Sheeran, and we just looked at coping planning interventions. And again, we showed that there is a big effect if you do have a coping plan, and then you're much more likely to be successful. And then also we elaborated on this additive effect. So if you have both action plan and coping plan, then you're much more likely to be successful as compared to only having an action plan.
Wow. Okay. So planning for a behavior, but also planning for the barriers or the challenges and obstacles you might overcome or have to overcome is better than just planning for the behavior itself. Is that accurate?
Absolutely. Yes, that's correct. So that's also the literature I've mentioned around relapse prevention. So when we talk about relapse prevention, we also talking about, situations of failure. So let's say you're planning to quit smoking, you decided, on Monday, I will throw away my cigarettes and I will no longer smoke. And then come Tuesday, Wednesday, you go to the party and someone offers you a cigarette and you just kind of join in and smoke again. So relapse prevention is, we know this may happen and it's very likely to happen. So it's this idea of, okay, what do we do how do we prevent relapse in the first place? So maybe if this is a week when you decided to quit smoking, maybe you just don't go to those parties that all of your friends are there and all of them are drinking and smoking. But it's also planning for if the things don't go up to plan and if you kind of didn't really do what you planned to do, how do you go back on track? There is also tons of literature where people talk about diet and healthy eating and studies on diet and dieting. And there is a large body of literature that basically looks into what happens with people when they start eating healthy, they follow the diet, they adhere very well. And then at some point, they have what they call a blowout, when you basically just, instead of adhering to your diet, you have, a huge lunch, lots of unhealthy things. And very often people will go with this kind of black and white thinking where, you're kind of off the wagon and you're no longer on a diet. So you may as well continue with no longer eating healthy. So if you look at this from a psychology perspective, that's a classic example of relapse. And again, what we teach people to do is it's fine when situations like that happen. We all human, we're very likely not to follow through with our plans. But what really differentiates people who are successful in health behavior change and also successful in long-term maintenance is this ability to pull yourself out from the situation of relapse, is this ability to go back on track, to basically, go back to what the plans were, to kind of forgive yourself, again, in brackets, for what happened, and kind of just appreciate the fact that it was just momentary.
Yeah, okay, so the blowouts, I can certainly relate to that. I'm in the Sunshine Coast now. Oh, yeah. I mean, I was in the Sunshine. I'm in the Sunshine Coast now. I was in Sydney last week, and as soon as I got back to Sydney in my old environment around friends and family, I had a bad day of eating, and very quickly that turned into, well, I'll just start my quote unquote diet when I get back to Sunshine Coast. So I think a lot of people can certainly relate to that. Is how do we kind of go about getting out of that when you're in it? Is that having that relapse prevention or that coping planning beforehand, before you're in that environment, or when you're kind of in it and you've broken your diet, so to speak? What can you do to get yourself back, or do you have to just wait till Monday to start again?
Whatever works for you, I guess. I think I really love the example you've given of kind of being outside of your routine, because again, there's a lot of psychology. There are a lot of psychologists who actually tested this, and they show that you're much more likely to adhere to your healthy habits if you're in your normal environment. So if you have an exercise routine, if you're eating relatively healthy, that's usually much easier in your normal everyday context and environment. And things very often become more tricky once you're outside of this routine, because there's a variety of cues in your environment that prompt you to not necessarily be active or to eat something unhealthy. So in that terms, we also often talk about this window of opportunity that opens if you change your routines quite radically. So there's a lot of studies that show that when you move from let's say when you move from high school to university, that's when you have all these opportunities to change your habits, to be healthier, to pick up a sport, to kind of think about what sort of foods you're eating, etc. But there is also a window of opportunity that things may go the other way, unfortunately. So that means you become less healthy, and you pick up those bad habits that you may have not had before. But going back to your question around how do we prepare or how do we do things afterwards, I guess kind of acknowledging the fact that those barriers are very normal and we're all experiencing them. And then after the fact, also acknowledging that, your identity is around being actually quite active. Your identity is around eating quite healthy and not necessarily, eating fast food every day, and just, kind of giving yourself a permission to, be unhealthy every now and then, because I guess it's part of our lives. I think that's what works for me, at least.
Yeah, and I suppose that alludes back to that black and white mentality that you were kind of describing earlier, and acknowledging, right, that there is some gray, and what that gray is for you, and just because you have some gray doesn't make you unhealthy, full stop, or black and white in that sense.
Absolutely.
Yeah, and it's really interesting what you say about the change of environment. Again, I just moved up to the Sunshine Coast about 6 weeks ago, and I think when I did move up, having read through your work, spoken to Ben Gardner, Pippa Lally, understanding that window of opportunity, those first couple of weeks I made a real intention to try and set good habits, to buy the healthy food, to get into my exercise routine regularly, knowing that it's a brand new environment. I don't have those kind of cue response associations that underpin habits. So those first couple of weeks are those really important reps to try and set the habits, and then it becomes easier. That's my interpretation of the literature. Is that how you would go about it?
Absolutely. So I think it's a classic kind of, what you're describing is a classic habit formation. So, you have your cue response, you're in a new environment, and by repetition, you're reinforcing the habit. So, there's a lot of myths around, it takes 63 days to form a habit. We know that's not necessarily true, but it definitely takes time. So it's not a one-off. It's definitely doing things over and over again till they become your second nature.
Yeah.
And I really admire that, you're not only a psychologist when it comes to your work, but also when you work on yourself, you're also making use of those techniques. I think that's really cool. And I feel like I do the same, and I can really relate to what you were saying around traveling. Because when I travel, I feel like I want to try all the foods. I want to do, everything. I not necessarily want to be staying indoors and gymming, which again, I think it's totally fine. But definitely for you, for our listeners, I think taking on those opportunities, but also kind of remembering that we are in control of our environment. So,
Okay.
restructuring the environment, taking into account, how accessible are healthy foods, thinking about where are those opportunities to engage in physical activity, especially in terms of physical activity that you enjoy doing and you think you can maintain it long term. I think that would be one of the key suggestions.
Yeah, really important point I think you bring up about the enjoyment side of things as well. So when we're trying to change behaviors, whether it's exercising, eating, how important is it to have something that you do intrinsically enjoy versus trying to quote unquote push yourself to do what you think is the most healthiest behavior, but you may not necessarily enjoy. So I think of like HIIT exercise, high intensity interval training, or I hate going for a run, but I know I need to, so I'm trying to find some more enjoyable way of doing aerobic fitness. But how important is that enjoyment piece when it comes to actually making something stick as a habit?
Yeah, great question. Extremely important. So the literature you're referring to is by Deci and Ryan, which is self-determination theory. And they've published a lot around how important is your intrinsic motivation and how impossible it is to continue doing things that you firstly hate doing, but secondly don't have control over. So when someone forces you to do something, when someone says you have to be doing it, if they put the incentive in front of you, let's say it's a very boring job and they say, well, you would still get paid. I mean, you're likely to do it because the incentive is there and you probably need to pay your bills. That's fine. But I think when it comes to health behaviors, our intrinsic motivation is so important. And what we eat, yes, of course, we have to eat healthy, but we also have to eat what we like because, no one can force themselves to eat stuff that they don't really enjoy. So I have an example for you. Myself and some colleagues, about 5 years ago, we did a study which was called Australian Funds in Training. And it was really amazing study. We brought middle-aged, overweight men to the stadium. We had set up a partnership with the West Coast Eagles and Fremantle Dockers, that are the leading AFL teams on the West Coast here in WA. And we basically told men, please come take part in this weight loss and healthy lifestyle program. You will get to meet the players and you will get to see the behind the scenes. So you will see the changing rooms. You will be sitting in those sweaty rooms. I thought that's not very appealing, but the men thought differently. And I've been doing weight loss research for a very long time. And what we always struggle is to bring men to do any weight loss or to kind of come and voluntarily participate in weight loss studies. For this program, we only have 120 seats, and within literally a few days, we have more than 3 times the number of people wanting to join and sign up.
Wow.
I've never seen it before, and it's not because of the great behavioral science content that we were designing and developing, and we know this. Men wanted to come because they love football. They loved AFL, and they loved their team. The way how we advertised it was via their AFL teams. So they were like, I want to be training behind this thing. I want to be training with my team. I want to be, at the place where they are. So we brought all the men, and we basically delivered a 12 weeks, very intense, healthy lifestyle program, which was also quite effective. We showed significant results in terms of weight loss. But we also showed that one of the most important factors that differentiate men who are successful with changing and maintaining their weight loss was simply enjoyment of activities that they started engaging with. So men who reported that they actually pick foods that they like but are very healthy and aligned with their healthy diets, men who picked exercise style and type that aligned with what fits with their routine and what they simply enjoy doing, they were the most likely to lose weight, and they were the most likely to keep it off long term. So that's just one of the examples of how do we encourage people to do that, and how do we encourage them to maintain it long term.
Wow. Okay. Yeah, I love that example. Really illustrates, the importance of enjoying something in the moment. And I think as the budding researcher in me tells me that I need to set up a partnership with an AFL team to help all my recruitment issues with my studies. So, yeah, really cool.
Oh, they're very difficult to bring on board, but good luck.
Oh, yeah. Yeah, see how we go.
Hello, everyone. A quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology, but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode, so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode.
I suppose that the flip side of that coin then, Dom, for me anyway, is willpower, self-control, self-regulation. And you kind of see on the Instagram world and, even sometimes in the pop psych world, the importance of willing yourself and pushing yourself to do your gym routine, to eat healthy. If you want it bad enough, it'll happen. What does the actual evidence and research say on the notion of willpower and self-control when it comes to changing some of these health behaviors?
Great question. So what we know about willpower is it also varies from person to person. So there are people who are fantastic self-regulators who can really, make themselves do stuff that they not necessarily enjoy doing. And, there is a sort of a spectrum of how good you are with self-regulating versus to how terrible you are. And we know that people who are relatively good self-regulators, they actually benefit less from action planning and coping planning because they already naturally quite good with self-monitoring and self-regulating. And people who are not so great with as self-regulators, they actually benefit a little bit more from action planning and coping planning. And the rationale there is because they probably haven't been doing that very well in the first place. Whereas for good self-regulators, that may come a little bit naturally, and that's what they do. How sustainable it is, I don't really have any good evidence I could be citing here. We know that people, if they're given a right incentive and if they're in a right mindset, they can continue self-regulating for a very long time, and they can continue doing what's desirable, what's required of them. The one thing you brought up is around, the Instagram, the pop science that says, if you really want something, you just put your mind to this.
Yes.
I mean, if that was that complex, we will all be, skinny and healthy, and we would all be able to, run 10, 15K with no stopping. It's definitely not that simple. It's the complexity of it brings into account your personality traits, but also how motivated you are, how important the given behavior is for you at the moment. How good is your support system? So people around you, people who influence what you do, how you do it. And then I think the final one is around environmental impact. So if you think about, some people, yes, they can be excellent self-regulators and they can eat very well, but that's probably because this is a core thing they can focus on, and the environment doesn't really pushes them towards engaging in other activities. So I think the good example is there was this very famous influencer who basically posted a picture of herself a few weeks after she delivered her third baby. And the caption was, "What's your excuse?" And if you think about this, there's a lot of moms sitting there at home thinking, well, I still haven't lost the weight. I still find it very difficult to juggle the time, find the time to eat healthy, find the time to exercise. And then if you kind of look into the situation deeper, you see that this person is not only famous, this person also has a massive support in terms of, getting the right nutrition, getting the childminder, getting, time to take off from being with the children and actually exercising. So, in a way we say, oh, it's all about willpower, but I feel very strongly, and science back this up, it's never only about the willpower, and it's also about all those other socio-environmental factors.
Yeah, I suppose it even brings to mind the perils of comparing yourself to other people on social media who are posting their highlights but not understanding the nuances, like you said there. Okay, on face value, this person is just delivered a baby and really fit or whatever it was, but not understanding that she had that environmental support could, I can see, send someone down a really poor self-esteem spiral of, what is my excuse? We're on the same boat and I haven't achieved this X, Y, and Z. So I think that's a really good point. Yeah.
Yeah, I think it's also a lot around social comparison. So, we compare ourselves to people who have usually a lot of time on their hands to be posting, a lot of money to be, editing, airbrushing photos and content. And, how realistic is this, and how worth is it our time to be doing any of those comparisons?
Yeah. And the old adage of, people aren't posting their lowlights on social media. It's always the highlights, and you're sitting there, comparing your average life to their well above average highlights that don't depict what's happening on an everyday sense. So really important with the social comparison side of things. Dom, if we talk more now about healthcare practitioners, so psychologists, GPs, physicians, people in those kinds of positions, how easy or hard is it to change their behaviors in their particular roles?
From my experience, is extremely hard. So I mentioned to you that myself and some colleagues, we ran a study in 3 hospitals here in Perth, in Western Australia. The study that I'm referring to was called PATHS, which is an acronym for Physical Activity Tailored Intervention in Hospital Staff. And the idea was we really wanted to deliver this intervention to clinicians, and we said anyone working in hospital can participate. We were recruiting medical doctors, nurses, any hospital staff that had any interaction with patients. And basically what we were set to do, we came up with this great idea of if we manage to deliver all those great behavior change techniques to healthcare professionals that inspire them and encourage them to become more physically active, then we not only improve their health because they would be doing more physical activity, they will be gaining all the benefits of being more physically active. So, better physical health, better mental health, but also in the same time, we will teach them what are those behavior change techniques that you need to use in order to change behavior. So then they can teach their patients. So we thought, perfect, getting them healthier, and we also educating them about the psychology of behavior change. So then they can use that psychology when they interact with patients. So also their patients are getting healthier, fitter, and more active. So we ran this study for over a year. We basically were recruiting across 3 different hospitals. We were measuring with the activity monitors physical activity before the intervention and then 3 months after the interventions. And we were looking if there are any significant differences from before to after. We also have different sort of content that we were delivering to those healthcare professionals. So we have some healthcare professionals that we only talk about action planning, coping planning, and other ones we were talking not only about action planning, coping planning, but also about self-regulation and motivation. And the final one was we were also talking to them about habits. And there's also a control group which gets no intervention. We just say, this is the guidelines, please follow the guidelines, but we don't use any behavior change techniques. So the intervention is an online delivery intervention, very tailored. They fill in some questionnaires. They got really tailored content, and we hope they love the content and they change behavior. And then after 3 months, when we look at the results and also when we interview the healthcare professionals, we realized that they absolutely hated this intervention. They said, firstly, it didn't fit with my schedule. There was a lot of text. You wanted me to answer lots of questions. You wanted me to read a lot of your content. I had 0 time to actually engage with this. This wasn't fit for purpose. I was hoping you give me like a gym session I can go to. And so firstly, we didn't meet their expectations. But secondly, we also looked at physical activity results as objectively measured with those monitors. And we've realized that actually every single group that we had in this intervention has improved their physical activity. So even a control group became more active. The motivation group became more active. The self-regulation group became more active. The habit group became more active. So then we were like, okay, what's going on here? So the article that we published actually quite recently, it's also with Ben Gardner and other colleagues. That's when we actually analyzed the interviews that we did at the end and when we asked those healthcare professionals. And we said, listen, what's going on? How did you manage to change your behavior? Have you actually used any of those techniques that we train you to do? And knowing that a lot of those people haven't even read the content, and knowing this objectively because we saw how much time they spend on the website, we got really interesting results. So firstly, we realized that intuitively people just engage in those behavior change techniques anyway. So in a way, it didn't matter which sort of behavior change techniques we prescribed them. They were doing a variety of behavior change techniques. They were coping planning, action planning. They were planning to do something repetitively in the same context. And that was completely regardless of what advice we given them, which kind of the main conclusion was, you don't have to be very prescriptive. You don't have to be very specific. A lot of this stuff is very intuitive. Secondly, they all became more active because we kind of brought their attention to the fact that they actually want to be more active, that they actually want to be more healthy, that they actually want to invest in their own health. So very often they would say, I love the fact you gave me this device, and I love the fact that you're actually checking how active I am and how much I improve. So I try to do my best. And we heard this from people who were in the most intense condition, but we also heard it from people who were in a control condition, which when it
Right.
comes to, averaging effects across different conditions, we were thinking, wow, okay, real life science. And I
Yeah,
think the third
jeez.
conclusion we had from this study was you have to really, really think about what's needed and what's suitable for your intervention group. And now it seems like a no-brainer. And every single digital health intervention I design, I co-design this with participants. But this
Okay.
one, we really didn't. We had another intervention that we were building from. We assume as a bunch of psychologists, we know what's going to change behavior. And then a lot of those participants says, why did you think that's going to work? And we kind of went back, rediscussed and thought, yeah, we should have asked you before we started, not once we finished.
Yeah.
So that was kind of our third conclusion on that one.
Right. Wow. Okay. So lots of lessons there. Geez. So when you say co-design, are we talking before you build the intervention, actually getting your kind of finger to the pulse and your ear to the ground, so to speak, to see what's already happening?
Absolutely, yes.
Okay.
So this is basically what I now do by default. So instead of saying this seems like a good idea, I always
Mm.
go to the population I work with. So to give you an example, myself and colleagues, we recently got over $1 million Australian to design
Cool.
intervention for people with disability and carers. And this intervention is called Connect App.
Okay.
But we spent about 3 years till now prototyping and co-designing with our users groups. So we brought
Okay.
into the room people with disability, we brought into the room carers, and we asked them about how do you want this intervention to work? What do you want us to do? So the final product is basically this online digital platform where people can create profiles, set up their
Okay.
preference, and say who they want to connect with in order to become more
Mm.
active. That works for
Okay.
both for carers, for people with disability. And we now kind of rebuilding this intervention to become
Mm.
firstly Western Australia wide and then to become Australia wide. But we're not
Mm.
launching it yet. We're not kind of jumping into implementation. We're still kind of pulling it back, going back to people with
Mm.
lived experience and asking them, how do you want us to deliver it? How would you use
Mm.
this? Why would you use this? What do we have to do in order for this to be effective for you specifically? And I think if you gather enough voices of people
Yeah.
who are experiencing a certain condition or who are trying to engage in behavior that you're trying to promote, you're the most
Mm.
likely to get a product that at the end, they like it, they want to use it, they want to pay for it, and it's actually meaningfully changing their behavior.
Yeah. Wow. Okay. Lots of lessons there. I think particularly for myself, even just as a early career researcher, just thinking. I mean, I almost feel like I have this kind of bias of, cool, I read the literature. I am a psychologist myself, so my PhD is in psychologists and changing their behavior. So I already know what's best, but I think there'll be a lot of assumptions there. But if I did co-design, like you're kind of advocating for, that might be not met. That I really should check, and the only way to do that is by getting your ear to the ground, like you're advocating for.
Absolutely. And I think you also hear voices from different perspectives and you kind of start thinking about things that you may have not considered yourself. So I
Mm.
think another thing that we always try to do when we co-design is variety of people, variety of social-cultural backgrounds, variety of
Mm.
experiences, variety of conditions. So you're not only hearing the voices that are similar to kind of your opinions and your
Mm.
attitudes, but you're also hearing people who may have conflicting opinions, who may be, slightly different than you are. Because I think that's very normal. We surround ourselves with
Yeah.
people who have very similar views to us. And then very often when we try to design for a general audience, we kind of don't have the variety that we need. it's very good to get people in the room who have very conflicting views, who are questioning what you're doing, who are questioning if it's going to work, because they're going to approach your project from very, very different perspective. And there's a lot of this, if you think about science of marketing, when you do your initial scoping, you find yourself 10, 15 friends who would say, oh yeah, your product is great, definitely it's going to work. But who you need are those critical friends. So you don't need, your family and friends. You need kind of a more critical mass to think about your intervention, to think about your project, to think about your study, and also kind of envision things that can go really wrong. Because I feel like a lot of studies we've worked on, the things that could go wrong, they did go wrong, and things we haven't even thought they might go wrong, they also went wrong. So kind of, planning for what sort of things may not work, but also what sort of bad things may happen will save you a lot of time in case they do happen.
So interesting, the getting the diversity of opinion or approaching people who maybe naysays or critical, and I wonder how much of that is like you know it's valuable, but on some unconscious level you don't want to because it's going to be aversive or it's uncomfortable. It's easier to just get the people who say yes and be your biggest fans, right? And it's more uncomfortable cognitively to deal with the naysayers, to, like you say, wrestle with all the situations where things may go wrong.
100%. But then I think you also have to consider who are you designing for. And if it's general public, you have to have a diversity of voices. And as uncomfortable as it is to get disagreeing voices or to get people who may try to put you down or be negative, at the end of the day, you want to have a meaningful piece of research. You want to have an impactful product that it's worth, spending time on. So I would always advocate for that diversity.
Yeah, fantastic. Well, no, this has been a really cool conversation, a very wide-ranging conversation, Dom, from value for consumers, for your everyday, quote-unquote, people, for clinicians, and for researchers as well, I think. So really appreciate that. But I know you're doing some really cool translational work for healthcare practitioners and psychologists. So how do people reach you and find out a little bit more about some of that cool work that you're doing as well, Dom?
Thanks for asking. So one of the things I'm heavily involved in is practical health psychology. So this is an online publication that's set to inform healthcare professionals about practical behavioral science. The way to find us is you go online, www.practicalhealthpsychology.com, and this blog is translated into 30 different languages. And we have a team of 65 national editors who translate behavioral science. They translate it and they contextualize it, because we know one of the barriers to use our science is also the fact that science is often done solely in English, and people who are practitioners across the world not always access it. The way we source our posts is we ask very prominent health psychologists and behavioral scientists. We ask them about what's the key area that you are knowledgeable about that's really practical and that's really applied to medical professionals. And we ask them to write a short blog post with really actionable recommendations for how to use it in practice. So far we've been really successful. We have 120,000 readers and viewers around the world, and we hope to grow, and we hope to publish more topical science as we go.
Yeah, fantastic. I'll certainly link it in the show notes, Dom. And I've written the name of the blog down, so I think I've got my evening reading sorted tonight.
Thank you.
But yeah, thank you for coming on, for sharing all your wisdom. Yeah, it's been, like I said, really cool just to read through your work. It's informed a lot of my own plans and research, and anticipating a lot of value for people listening as well. So really appreciate that, Dom.
Amazing. Thank you so much for the opportunity, and good luck with all your work and your research.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former And if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental well-being. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.